Right. Good morning, afternoon, everyone. Mostly, at least here in the UK, it's good afternoon. I'm Lenny Shawcross. I'm the Executive Director of World Dementia Council. We are based in London, but I'm actually speaking to you from the hills of rural Wales, for those of you who know that. So it's a slightly chaotic background behind me. And what you can't see over here is the mountains of Wales. But hopefully the internet will hold up and I will be here for the duration of this, but Ishtar will and Roger will do a brilliant job chairing it. So first of all, thank you very much for joining. I'm just going to say a few words by way of introduction. So firstly, let me say something about the council. It was founded by the UK government following a summit they held in London in 2013 under the then UK Prime Minister David Cameron. And what the council does is network global individuals who are thought leaders in this space, and we develop insights and recommendations and policy based on the contributions from these participants. You can see on the left of the slide that we do a whole series of events, some in person, some like this virtual. These can be a kind of at government meetings. So you can see on the left one with the government of the Netherlands and one at the G7, which took place in Nagasaki a couple of years ago. We do events ourselves. We do a summit every year in London. We do one in China. And we hold a whole series of virtual meetings for individuals to share their thinking and insight. The council is chaired by Dr. Joanne Pike, who is President and CEO of Alzheimer's Association. You can see her there in the middle of the screen. And we have a new vice chair who is starting as of now, who I'm sure lots of you will know, Professor Paolo Caramelli from Brazil. His first time the council has had a chair or vice chair from the region, and the first time we've had actually someone from a low middle income country. The council itself is an advisory board of 25 members, including Ishtar, and they are drawn from leaders around the world and from different areas of dementia fields. So as you know, we are hosting a whole series of virtual dialogues that are looking at dementia in Latin America and the Caribbean. We have held 3 already, which you can see there on the screen. All of these have been in Spanish, and we are holding 2 now in English, more focus on the Caribbean itself and the English-speaking Caribbean, and this is the first of them. And you can see there's more on our website, World Dementia Council /Dementia Dialogue, which you can see there at the bottom of the screen. All this is leading up to our first satellite summit that we are holding in Lima, Peru, in partnership with Alzheimer's Association. It's taking place on the 13th of May, next month, actually, and it's happening the day before the AIC Satellite Symposium, which is taking place the Wednesday and Thursday of that week. And again, there's some more information on our website, /Peru-Summit. The summit itself is going to be in Spanish and English, and it will look at the research and care landscape, and also how you deliver change across the region. So very briefly, before I hand over to Ishtar, we are doing kind of 3 projects in addition to this going forward. You can see visuals of them because although they are all actually kicking off over the next couple of months. We are doing a piece of work that's looking at innovation in biomarkers and the development of biomarkers, which you can sort of see represented graphically on the left of the screen. In the middle, we are doing a piece of work that's looking at the changed advocacy landscape in an era of treatments. And finally, on the right, we are going to be looking at what both the changes in advocacy and treatment landscape means in particular for dementia policy and advocacy in India. And finally, as part of our partnership with Alzheimer's Association, we publish the outcome of these meetings in Alzheimer's and dementia. We have a monthly column there, and it's you can get it from the website, directly from our website, of course, straight from Alzheimer's and dementia. We, as you will have seen right at the top, we record this meeting because we do produce a transcript, and from that transcript, we produce an article for Alzheimer's and dementia. So with that, I am going to say thank you very much to the hosts of this meeting and also the people who are speaking, and turn it over to you, Ishtar, to kick the conversation off.
Lovely. Thank you so much, Lenny. Good day, everyone, and welcome to this first session of the World Dementia Council's Caribbean Dialogue Series for April. So lovely to see so many familiar faces and friends online. I'm Dr. Ishtar Govaya, a public health scientist, a regional advocate, and as Lenny said, a nominated member of the World Dementia Council. I'm also co-chair of today's session and CEO of Amaji Health Limited, an organization committed to equitable health system transformation across the Caribbean and other low and middle income settings. The World Dementia Council has held 3 dialogues in Spanish focused on Latin America and the Spanish-speaking Caribbean. And today we begin a new phase. This session and the one to follow on the 25th of April centers the English, Dutch, and French-speaking Caribbean, many of whose nations and territories are small island developing states with large interior and rural populations. These countries face a unique convergence of vulnerabilities: climate instability, tourism dependence, significant informal economies with related challenges to employment and social inclusion, brain drain, high non-communicable disease burden, and rapidly aging populations living longer, all of which intersect meaningfully with the dementia challenge. We often speak of the Caribbean with pride, and rightly so. The Caribbean was globalized long before it was a thing. The Caribbean region is a hub of innovation, athletic, intellectual, and artistic excellence and achievement. But the health realities are complex. For example, we are the fastest aging region globally. In Barbados, the diabetes-related amputation rate has earned it the title amputation capital of the world. Many Caribbean countries lack regulatory systems mature enough to protect the public from substandard or falsified medicines. It is also a region with an increasing population of people living with dementia. Dementia remains under-recognized, underdiagnosed, and often under-prioritized. Yet its burden is growing fast. Our systems are simply not prepared for it. The conversation around dementia globally is shifting toward earlier and even preclinical diagnosis, blood-based biomarkers, and disease-modifying therapeutics. These are important developments, but they raise difficult questions for our Caribbean. What does early or timely diagnosis mean when there is limited access to basic diagnostics, patchy access to medicines, and fragile health data systems? How do we ensure that innovations are ethically integrated, equitably accessed, and strategically contextualized? These are some of our concerns in today's session. It is not about repeating global priorities. It's about translating them to our Caribbean realities. This session is meant to offer insight, connection, and urgency. You'll hear from speakers bringing data, regulatory insight, tech innovation, genetic science, and a lot of experience to the table. Each of them helps us see more clearly where we are and how we might chart a more joined up and resilient path forward. So before we begin, just a bit of housekeeping. Please keep your cameras on if possible. We want this to feel like a conversation, not a webinar. Please keep your mic on mute when others are speaking. Each speaker will offer a short provocation, 5 to 8 minutes maximum. And after they all speak, we'll open the floor for wider discussion. Your opinions, your insights are deeply important to this conversation. Please feel free to use the chat or raise your hand at any point during the open discussion. As Lenny said, this session is being video recorded. We're so grateful for your company today. We need many hands and sharp minds to face the challenges ahead. This isn't about doom and gloom. It's about clarity and Caribbean-powered solutions. Let's get started. I now hand over to today's co-chair, Dr. Roger Roberts, Jamaica's only neuropsychiatrist and the pioneer of Jamaica's first neuropsychiatric service at a public hospital, to say a few words of welcome. Roger, over to you.
Thank you, Ishtar. I would like to take this opportunity to welcome everyone to this, what I consider very important discourse. I know that usually in the discussion, the Caribbean is forgotten. We are some tiny dots on the map, but I'm happy to be a part of this forum. And I'm hoping that coming out of this discourse, there will be some actionable items. In 2019, I returned to Jamaica. And as the only neuropsychiatrist, I would manage a range of complex disorder, but I recognize that a large part of my population involve patients living with dementia. I can tell you that the Caribbean, there are certain unique challenges. Of course, there is the issue of human and non-human resources. We're talking about deficiency in terms of the specialists that is required to build out specialist pathways. Neuroradiologists, neuropsychologists, neurologists. So we have the deficiency throughout the Caribbean. And then there is a disparity in terms of the urban and the rural setting. I can tell you that in Jamaica, we have been training more psychiatrists, for example, but they have opted to remain in the urban centers and not go into the rural areas. So the question is, how can we provide, that kind of a specialized care to the population in rural areas? Also, there are competing priorities for the Caribbean. We know that we still have the NCDs, and diabetes, hypertension, major cause for morbidity and mortality, and that will put a strain on budgetary allocation to build out dementia care service, which, by the way, we are really in need of, because as Ishtar mentioned, the population is aging, and age is, as we know, is probably the strongest independent risk factor for dementia. So we need to prepare for what is to come. What I will start off the discussion with actually Dr. King. Welcome, Dr. King. I would like to start off discussion with you. And my question to you is, how can population-based projections and estimates of economic impact guide us in shaping dementia-related service in the Caribbean? And just context as well, I mentioned about the urban-rural disparity. How can we factor in that as we build out services?
Thank you. Thank you, Dr. Roberts. I've prepared a few slides, which I'll share now, which hopefully will help guide my response to your question.
All right, go ahead, Doctor.
So my background is in economics. I'm a researcher at the London School of Economics in London and in the UK. And one of the things that we work on is in terms of projection modeling of these approaches to dealing with conditions such as dementia, and also in the case of services for people at older age. So specifically thinking about the Caribbean, I've drafted this short and brief model of how I think the pathway would be in terms of looking at some of the issues in relation to costs and outcomes for people with dementia and their families. It's important to say that this is very basic and it focuses on costs, but we're also obviously interested in other outcomes in terms of the well-being and quality of life of the people that we're speaking about. Obviously, too, one of the things that I would say how this benefits us is in terms of planning, in terms of future programs and looking at what the impact of expanding demand for services for people with dementia will look like in the future, but also making the case for interventions in terms of how can they be judged to be cost effective if we're able to show potentially that they may have some savings in terms of costs in one location of this pathway, but may also have some costs. So this type of model allows us to make some of those comparisons. So firstly, I would start by speaking about the number of persons with dementia. We have population estimates from the UN Population Division, and also some estimates in terms of incidence, prevalence, and trends over time from the PAHO 2023 report. And as you quite rightly mentioned, the data does suggest that there is a disparity in terms of prevalence between the urban and rural areas. Also, we know that dementia progresses in terms of prevalence with age, and there are also some socio-demographic differences in terms of these factors. We also may want to consider whether or not there are different rates in terms of education or cultural backgrounds or other individual factors. Then we can think about families and friends who provide unpaid care. What are the numbers of these people in terms of their distribution within the countries that we're looking at? And also in terms of other paid informal carers, what are their numbers and how many people are they supporting in terms of that dementia journey? We also want to think very carefully about diagnostic rates. We know that across the world, and particularly in some of the middle-income countries, rates of diagnosis may not be as high as we would like, but obviously this then has some impact in terms of provision of services. The more people you diagnose, the more services that you will know are required. We also want to think about access to services. So what data can we find in terms of how ease of access and the number of people accessing services? In terms of thinking about the individuals who then provide care, what numbers of hours can we estimate in terms of the number of commitment that they hours in terms that they provide to the people with dementia? And also in terms of paid informal carers, Ishtar's paper was very clear in identifying domestic workers as a key source of support for people with dementia and their families. And again, what are the number of hours that these people are providing in terms of supporting people with dementia? You mentioned services and formal services and the lack thereof. We want to think about what services they are. These could be health services, but they could also fall within the social care sector. So things like home care and respite care and meal services, potentially some residential care services and other services. Then in thinking about how this impacts the economy of the Caribbean region, we think about the costs to persons with dementia and their carers in terms of the out-of-pocket costs that they're experiencing, and also some of the opportunity costs in terms of lost employment and costs for aids, equipment, and adaptations. In terms of carers, we also want to think about their own health care. So there may be that the strain of providing care and support has an impact on their own health, and we want to factor that in terms of how we look at modeling the costs of care. And then in terms of informal care workers, do we have any sense in terms of what these costs in terms of the amount that families spend in terms of employing informal care workers? And then finally, in the formal care sector, what are the unit costs of public, private, and voluntary sector services? And how can these be modeled in terms of providing some information in terms of this care pathway journey? So I will just end there and again say that this model is designed very basically to look at the costs of outcomes and what we can try and model in terms of the impact of dementia in the Caribbean region and ways in which we can use this type of model to look at interventions and how they could be judged to be cost effective or not cost effective. Thank you.
Thanks so much, Derek. That was really helpful. I think one of the main messages that's going to come across during today's conversation is the need for data. And we have some very experienced people who are going to be speaking to us officially about that, but many of you on this call also have a lot of experience in terms of grappling with the question of what type of data are suitable, what type of data are needed, and given the limitations of data, how can we best go about modeling what it is we're trying to estimate, and in this case, these costs. So as Derek showed, these are preliminary thoughts in terms of how we go about doing the model, and we're continuously seeking the data inputs to be able to run these models as appropriately as we can. So now we're going to shift to Rochelle, Miss Rochelle Harris. Rochelle, you bring to this dialogue over 2 decades of working with and providing strategic advice to multilateral organizations, to governments and NGOs to address regulatory challenges and improve global access to medicines. So given this expertise, can you please share a bit of your thoughts about the biggest gaps that are affecting health system preparedness in the Caribbean? How important do you think regulatory harmonization is for improving medicine access and diagnostic capabilities across the Caribbean, and other thoughts that you may have in terms of market shaping with supply, etc.? Over to you, Rochelle.
Okay, thank you. Hi, good afternoon, everybody. Good morning to those of you not like me in London. So thanks very much, Ishtar. So yes, I have a background, just very briefly. I was at DFID as the Access to Medicines Policy Advisor, and one of the major programs that I was working on was on supporting global medicines regulatory harmonization, which was operated through a World Bank Trust Fund. And the largest portion of that work was focused on African medicines regulatory harmonization. So I come at this from that perspective, and then had done some work with the Caribbean regulatory system, which was another effort and attempt to increase regulatory reliance. So the reliance between member state national regulatory authorities on each other's decisions and information, or the reliance on another authority to support and to prevent the duplication of work within small national regulatory authorities. Regulatory reliance is considered to be a best practice. The most mature, most sophisticated regulatory authorities conduct regulatory reliance in order so that they can increase efficiencies and put their resources into the most necessary national efforts. So relying on trusted authorities allows you to avoid that duplication. So I can't promise that I can comment to you on health system preparedness in the Caribbean region. I don't promise to be able to do that. I do come at this through a regulatory systems lens, and some work in particular that we conducted about 2.5 years ago on the CRS and its role and potential and opportunities within the Caribbean system. So I would like to tell you just a little bit about that and the wider capacities and capabilities. So I think it's worth saying that as of the time that we were doing that study, only just over half of the member states within the Caribbean region actually had legal provisions requiring marketing authorization. So the need to be able to actually register your products and have them authorized and licensed nationally. And of the other a lot of the requirements are fragmented across different countries. So what is required as a company to go in and place your product on the market varies widely. And this is obviously quite a deterrent to companies. Also, given the fact that many of the markets are really quite small. So you've got a fragmentation in regulatory systems and regulatory requirements. You've got a fragmentation in import requirements, and also fragmented, rather small markets that aren't providing that pull for the companies into them. Of course, there is a pool procurement mechanism of the OECS, which is a collection of small member states, where there is a collective procurement that's conducted. And across all of the member states, there really is a struggle against an influx of substandard and falsified medicines, which are the real scourge for those purchasing medicines, and both in the informal and formal sectors. And so whilst, of course, there are many wider issues among resourcing, financing, product selection, prioritization, there is also a real issue around the regulatory, around access in terms of regulatory, and really in terms of the quality of medicines that are available, and the adherence to international standards and expectations of suppliers to meet those international standards. It's an incredibly variable space, and that's leading to really a vulnerability for patients who are exposed to medicines of dubious quality, medicines which not only the patients but also the prescribers may actually only be able to have a low level of confidence in, that they really are being manufactured to international standards. This problem is, and this problem partly stems from a lack of local capacity of the regulatory authorities. You're talking about human capacity and financial capacity within fledgling regulatory authorities. Sometimes these are just desks within the ministry. Sometimes they've been, obviously are standalone authorities. The ideal model is that each country has its own semi-autonomous regulatory authority, and working towards that, where a level of maturity is developed according to what the WHO uses a maturity scale from 1 to 4, with 4 being the most sophisticated. And so moving along that journey of regulatory maturity to be able to demonstrate a stable, well-functioning, consistent system that is transparent, etc., is really quite essential. That requires quite a bit of investment in terms of, as I said, both technical know-how, but also staffing and resourcing. And so in the absence of that, because of course that level of investment isn't necessarily available, politicians don't necessarily prioritize or understand the value of strong regulatory systems, of the role that they really play in enhancing access to safe and effective medicines. That has really encouraged partners like PAHO, with the support of the Gates Foundation, to really try to increase understanding and willingness to conduct regulatory reliance. And the Caribbean regulatory system was set up as a program under the auspices of PAHO in Trinidad, that would, within a certain prescribed scope of products that had been authorized by certain recognized authorities, that they would, once they were submitted into the CRS, that they would be assessed and then given a recommendation. This recommendation would then signal to member states that these products were good to go. They could be, without needing to re-review the dossier, these products could be licensed and imported. Great idea, really wonderful idea in terms of saving efficiencies, has done some really great work, really has focused on priority healthcare products, and in COVID really showed the way in terms of emergency use licenses. but it's not without its challenges. And so if I may, I know I've got some time limitations, but I want to just summarize some of the challenges. And if you'd like, I can go into these a little bit later. But, you know, one is that the decision is provided by this regulatory team sitting in the CRS under the auspices of CARFA. But, you know, the main thing are these recommendations being adopted by the member states. And whilst you see there is a tier of countries that have systematically decided to adopt any recommendation made by the CRS, Belize, for example, has said, we will automatically license that product. There's no need, you know, there's no need to reassess it. That product's coming in. Jamaica had made similar noises, but hadn't yet demonstrated a similar uptake, hasn't followed through. But unfortunately, the majority of the countries have left them perhaps skeptical, or perhaps without the capacity to even understand, engage with, and then set up a registration list within the country. So the lack of capacity has hindered adoption in some member states. And some member states are also concerned about a risk to national revenue streams from the license fee from companies. So that risk of, are we going to lose money into our authority from the application fee? Secondly, there is a lack of transparency. So there's a whole set of issues around delays to national uptake and divergent processes nationally. So a lack of transparency about country-specific processes, both for regulatory requirements and import requirements particularly, and the varying requirements. And a lack of knowledge and capacity across the regulatory bodies is really hindering this. There's a trust issue and recognition of reliance and reliance pathways that can be so useful. And so that skepticism or lack of understanding or appreciation of the benefits is holding things back. Industry has potentially not had the incentives to really come forward and put their products when they want to register them into this market through the CRS because of the user fee. So is the user fee that they're having to pay to the CRS seen as an additional, perhaps not value-adding layer of bureaucracy that they could cut out when they can go straight to country? And then in terms of substandard and falsified medicines and that response, really there's been a lack of know-how of how to report adverse events from medical products or falsified products and other issues relating to the products. So that, you know, there are under-resourced departments that are hesitant really to add more responsibility to what they're already overstretched. So I just wanted to finish with a few thoughts on what kind of foundational work could go forward. And the CRS is still going, it has expanded slightly. And you know, that there are, I would say, possibilities for partnership with some of the larger member states, if they can potentially reach out to some of the larger regulators through WHO. So WHO offers regulatory system strengthening, and some of the member states, as and when they're ready to increase their regulatory maturity, may have an opportunity to partner and twin with different regulatory authorities to build that capacity, thinking potentially of Jamaica. But of course, it requires political input and political support. And really, I think making the case to understand the problems of substandard and falsified medicines and why these undermine markets, actually. If you're talking to a politician, this has a real direct economic impact. Companies don't really want to play in a field that's dirty. Reputable companies, because they may get tarnished with that brush. And so often they may just stay out altogether. That leaves more of a possibility for companies that are operating with perhaps two sets of standards, one set of standards for products headed to the developed world, and then others for lower income countries where they know they can sneak the products in via weaker regulatory authorities. So making the case to politicians, I think, is absolutely number one, and that education and engagement to ensure that there is a kind of more of a fast track approach to building capacity and to using the CRS. And I think, you know, the CRS is not necessarily a closed scope, those conversations about, well, what is a health system priority? Just thinking about the dementia area. So I think that's one, is that political engagement. I think capacity building within member states, how can you ensure that the key technical leads are really well-versed on what is reliance, how to rely, why it's not undermining your sovereignty, but actually enhancing your capability and capacity, alongside basic technical support. And then I think industry engagement to help them understand what these facilitated pathways are, to really make sure that they can get into the market in a way that gives visibility actually to high quality products. Because what you want to do is you want to push out and eliminate those lower quality products. And so on, just to my very final point on this, is that we've been doing some work in the West Africa region for the Gates Foundation on enhancing and increasing the linkages between procurement, on the one hand, national procurement or regional procurement, and regulatory decisions. So that regulatory decisions that are made by mature, stringent, reliable authorities have more visibility to procurers, and that procurers are able to eliminate from any tender products that don't meet the minimum international standard. And we would say that maturity level 3 for a regulatory authority really is that baseline. So if a product is not approved by a maturity level 3 or recommended by a platform like the CRS that doesn't do approvals, but it does recommendations. So if it doesn't meet those minimum requirements, exclude it from your tender. So we've developed a product selection framework that countries can integrate into their national procurement system and filter into their tender and evaluation process, that enables them really to sort the wheat from the chaff. So happy to talk about that at any point, but thanks so much, and I hope I haven't gone over time too much.
Thanks, Rochelle. Roger, you want to transition to our next speaker?
Sure, Ishtar. I must say that I'm preoccupied with the thoughts of how are we going to actually fund DMTs. I know that we're not in a state of readiness, because of course we have to build out our diagnostic pathways to ensure that diagnosis is appropriate so we can get the best outcomes. But certainly in a Jamaican context, I can tell you that the regulatory system is quite complex. I consider it quite complex. For example, to get drugs on the VEN list, which is what they would make available to the public. For those who are not familiar with the Jamaica health system, it's free, and there's a public government-funded health system. And to get drugs available to the public, you need specialists to vouch for the drug, to say that there's benefit to your patients. And then the question is that, how can I vouch for a drug that I'm not using? And so it takes time, in fact, years sometimes to build up that experience. And oftentimes there is this health disparity, because it's those who are in the middle upper income may be able to afford the drug, and you will have to write to get special permission to import the drug. And this can definitely impact on cause unnecessary delay in approval. So I'm going to turn to Mr. Walker. I know that your company, Avento, is involved in aging-related pharma innovations, not necessarily dementia or in the neurology line, but what I would want you to share with us, based on your experience, what you think would be necessary to strengthen that public-private partnership to overcome some of the regulatory challenges that we face in the Caribbean. And I know that the regulatory system for the different countries, it varies, and it's quite fragmented, to be honest. So I would want you to bring your expertise to that area. And also, how do we strengthen the ecosystem in terms of the supply chain coordination?
Okay, great. So good morning, good afternoon, everyone. I will definitely try to be brief today, firstly, because I am losing my voice, and secondly, because I feel very much the least among these panel members. And Rochelle, I look forward to connecting with you afterwards. So just briefly on Aventa, it's a relatively new name, and I wouldn't be surprised if none of you would have heard that before. But Aventa is the Caribbean, English and Dutch-speaking Caribbean's largest pharmaceutical distributor. We also do manufacturing. The companies themselves have been around for a long time under different names. So in Barbados, for example, Collins Limited has been around since 1888. But all of our distribution businesses all renamed the last 2 months to Aventa. So we have businesses in Jamaica, Barbados, Trinidad. Trinidad is called Smith Robertson, and Curacao and Aruba. And we have our affiliates in Guyana, St. Lucia, St. Vincent, Grenada as well. It's part of the Agostini Group, which is based in Trinidad. It's a publicly traded company, celebrates 100 years this year. So in addition to the distribution, we do manufacturing. Carlisle Laboratories out of Barbados, which does his style line and a lot of OTCs, cough and cold, vitamins, and generics. The services that we offer are relatively broad in that space. So we are involved in market access, in regulatory services and support, product registration, activities related to formulary inclusion, quality and pharmacovigilance, as well as medical detailing, training, and of course, logistics and sales, which is a core part of the business. And we're very much, we represent many of the world's biggest biosciences companies, which all have their expectations around good distribution practices, and we are regularly audited by them. And so our logistics chain and our warehousing would be compliant with their needs. And it's certainly an issue that we see as well. And I do like that Rochelle highlighted the issues around substandard and falsified medicines. There is an issue with parallel trade in the Caribbean and some markets particularly challenging. You can go to pharmacies in Guyana and pick up a box in Turkish with 0 English on it. And you have no idea under what conditions that medication got to Guyana. Were there temp trails, and did anyone monitor the conditions? And the answer might be no. So that is a big concern for us as well, because obviously it's also a product that we might be marketing, but also showing up via parallel trade. And how do you trace that and keep the patient safe at the end of the day? So it was been alluded to before that we do have sort of 2 groups of markets in the Caribbean. And some people like to call them unregulated and regulated. There's no real such thing as an unregulated territory per se. But the requirements in Barbados, Bahamas, Bermuda, Cayman Islands, OECS, in terms of a product being able to be sold is far simpler than Jamaica, Trinidad, Guyana, Dutch Caribbean, and Suriname. So the time frames within that latter group of countries are a year plus. And in some cases, it's not even necessarily just for ethical products. We're talking about it could take a year to register a new flavor of Listerine in Trinidad. I mean, it's quite stringent. We are stringent. So it is a challenge for us, but we do have to operate within a certain stricture and in certain environment. So we do collaborate as best as we can. Are there good opportunities for CRS? Are there good opportunities for greater cross-country collaboration? Absolutely. And we'd be happy to support that. And I'm really happy to be here because I want to make some links with folks on this call to see how best we could support you guys going forward as you advocate for that like we would. I totally agree that the registration bodies are under-resourced. I actually think Rochelle is the opposite. I think the fees are too low because if it costs $100 US or something to submit a product for registration, well, anybody's submitting a whole bunch of products that may or may not ever sell or may not be needed in the market. In fact, one could argue that if you change the price point to make it more expensive, you'd be able to fund the body that's actually doing the work in a better way, hire more staff, train them better, bring in the tools that they need. This is one idea. I'm not saying you necessarily do this, but this one idea that maybe the fees are too low. And that's why that's a part of the reason why it's a bit under-resourced. So in terms of harmonizing and advocating for a more streamlining process, I'd certainly think that we would be supportive of that. And really, we do have to then focus on, well, what can we influence, but then what can we control? And so just a little bit about Aventa, right? So Aventa is part of Agostini, and within the Agostini group, Agostini had one company in Trinidad. And over the last 3 years or so, acquired the companies in Barbados, then Jamaica, then Aruba, Curacao, and whatnot, and brought them together. And part of the reason about bringing them together was around building a common platform across the English and Dutch-speaking Caribbean to purchase medications and have them available. So improving the security of supply across the region. Some of you all would have heard the term MOQs, minimum order quantities. And so you ask a small country, you know, like Aruba, to place an order with a big pharmaceutical company, and they may not be able to make it, or they may have to bulk order and order once for the year, and then you get into difficulties with expiries. And so that's what we're trying to overcome by transitioning to contracts with suppliers that would allow us to place one order for the Caribbean and then be able to move the product ourselves. And that increases the resilience within the system, and hopefully as well cost to deliver, and potentially even the negotiated cost of the medication itself. Not all suppliers want to do that or want to get into that sort of contracting arrangement, but we think it's a good opportunity, and in fact, it gives them a simpler approach to the region, because otherwise they're dealing with 20-something territories with different languages, cultures, regulatory processes, customs processes, people, and that's complicated too. So actually, if we can provide, and when I say if, we do it now, providing a simplified one-stop shop is really what our strategy is around that now. That requires regional forecasting is not easy. I mean, Ishtar, you talked about data. It's not easy. We don't have third-party data we can buy around scripts and stuff like that. We do have to try our best where we can. We do have a project in our innovation lab in Agostini called the Dolphin Data Suite. Well, Dolphin is actually a platform now in Trinidad for coupons for your prescription medication. And so you can save on that. But the future of that platform is actually a data suite where we can start aggregating data. The group also had, I forgot to mention this up front, within our group, we also have retail pharmacies as well. So we have 20 pharmacies in Trinidad, 1 in Barbados, and our partner out of Barbados, Goddard's group, as well, has pharmacies in St. Lucia, St. Vincent, etc., which helps as well to have an insight into the retail space, because of the lack of the data. Actually, it benefits if you do have some insight, at least from on the retail side, the private trade, quote unquote, private trade side. What I say, and then maybe the last thing I would say, just to not keep it too much longer, would be that another thing Ishtar asked me before was around the importance of patient advocacy and around elevating the patient voice. That's something we really believe in strongly. And I think in dementia, it takes a whole other spin, because the people advocating for the patient may not be the patient, him or herself. And what does that mean? And how do you take that on board? So last year, we launched a program called the Impact Program. About 80 people from NGOs around the region, Antigua, St. Lucia, Trinidad, Jamaica, Barbados, have been part of this. And it's about building the capacity for that patient voice to be elevated. So we had training sessions on PR and social media and fundraising strategies and finance and governance and volunteer management and goal setting and planning and these kind of things, really to strengthen our patient advocacy groups, which we think is a big gap in the market, to advocate in particular for more advanced therapies that don't currently exist on the market. The reality is, in some of our territories, it's been many years since a drug has entered the formulary, which means that literally no new treatment has entered the public space for general broader access, like Dr. Roberts was saying, in some of our territories. And that really has to change, because we don't have access to the latest technologies if we cannot add that somehow. So I'll stop there, and I'm just thank you all again for allowing me to participate, and really look forward to connecting you. I want you to reach out to me and push me and my company as well to do things that would benefit what you're trying to do in this space. So I appreciate your time.
Thanks so much, James. I think the work that you're doing in terms of this regional coordination to aggregate the demand, it's definitely going to add to improvements in the supply chain reliability. And that, in addition to all of the work that's happening in parallel that we've been hearing about today, and we'll hear more about in the dialogue, even later on in April, where the co-chair for that is the director of surveillance and is in charge of the Caribbean regulatory system. That's going to also be a rich integration of some of the findings and the discussions from today, because we do need these data-driven approaches to improve regional stability. And we need the basic pharmaceutical supplies. We need those to be safe as we think about building out even more complex systems. So with that, I want to turn to Sylvia. So Ms. Sky, when you have extensive experience, I mean, you're in the UK, but lived and worked in Trinidad for such a long time, and you were the only specialist in Trinidad offering clinical scientist services, particularly in clinical genetics for hereditary cancers and other genetic conditions. So that's given you a real eye-opening exposure to the key barriers and facilitators to expanding access to genetic services in the Caribbean. So can you please talk with us a little bit about that?
Sure, thank you, Isha. Hello, everyone. Yeah, so just to preface this, that I'm kind of coming from this topic from a diagnostic perspective. So I've primarily worked in the process of giving patients a formal genetic diagnosis of a particular condition. Now, within dementia, this is rare, as although there are some forms of monogenic dementia for which a formal genetic diagnosis can be given. The vast majority of dementia is multifactorial with both genetic and non-genetic risk factors. And testing for genetic risk factors may not be recommended for individuals outside of a research setting, as the results may kind of only be informative on a population level. So in terms of genetic testing in the Caribbean, due to a lack of equitable access to genetic testing, currently there is widespread missed diagnoses. That is, persons who should have a formal genetic diagnosis and do not. We do not want to replace that with misdiagnosis, that is, symptoms being incorrectly attributed or risk being incorrectly attributed to one or more genetic variants when it's in fact much more complex than that, due to genetic testing being rolled out without adequate understanding or the safeguards for the individual patients. So as I just alluded to, there's this inequitable access in genetic testing in the Caribbean currently. It's not part of standard care, and it's not supported by public healthcare systems. Patients are advised to seek private genetic testing. This is in a kind of ad hoc manner, depending on which doctor they see. I facilitate access to that genetic testing. However, it is unaffordable for many. Previously, genetic labs in the US have had outreach programs and have encouraged genetic testing in the Caribbean. But this is more and more so becoming no longer the case. And simply put, the Caribbean market is seen as too small for a lot of these services. So some local labs are starting to offer some genetic services. However, there is not a requirement for labs to be accredited. Some do seek international accreditation. And as I mentioned, there's a concern that genetic testing may be provided without adequate understanding of its complexities, leading to suboptimal outcomes. So to answer your question, despite the reduced support from international labs, I see the key route to facilitating access to genetic testing coming down to upskilling people rather than technology or equipment. Although ultimately it would be fantastic to develop services within the Caribbean and to foster self-sufficiency in terms of that technology and equipment. we're a long way from being able to compete with the breadth and depth of testing available overseas, and not to mention the economy of scale that overseas labs have. And I do believe there are opportunities to forge relationships if organizations in the Caribbean, governmental and non-governmental, tackle the access to genetic testing. So I think we need to focus on workforce development, educating our healthcare providers, providing opportunities for people to specialize in genetics. There are enthusiastic people who want training opportunities, but these are not readily available. They apply to overseas programs and are often not accepted due to a lack of exposure to the field, because they have not been able to access that within the Caribbean. And if they are accepted, once they qualify, they often do not return, as there are no posts for them to fill. So really, I think the key to expanding access to genetic services, both within dementia and wider genetic services, is personnel. It's developing a genetics ecosystem that includes diagnostic professionals and a close collaboration with research.
Thanks, Sylvia. Roger, I'll take it, hand it over to you for the summary response and hand over to Doug.
Right. Thank you so much. I think that there's definitely a need for genetic testing to be available in a Jamaican context. I myself have patients that I know should be tested, but the unavailability is a challenge. And I know that you mentioned the diagnosis and research, but also in counselors, trained counselors as well, because we have to consider the ethics of it. Right, so I will now move on to Mr. Hal Saul. And this is a very, I'm happy to have him on the platform. And I tell you why. I think that we're in Jamaica, we have a major challenge with supply and demand when it comes on to pharmaceutical products. What tends to happen is that, let's say that there's a disruption in the supply chain and a particular medication is not available, we don't prescribe. And then the pharmacist will say that, well, we haven't procured the drug because you're not prescribing. So clearly there's a lack in terms of data to track the usage pattern. And I know that AI is a company that has been around for quite a while. They would have built up the national coding system for the National Health Fund, and for the non-Jamaicans, that's the public subsidiary program. And what I would like to know from him is that if he could share with us the work that he's doing in terms of incorporating drug coding in the electronic medical records and just overall the health system, which I think will be very important in terms of data capturing and standardization. And I think that this can really inform how we prepare our health system. Mr. Halsall, over to you.
Thank you very much, Doctor. And thank you very much for the opportunity to share our experiences with you. Due to time, I'm going to give you a very high-level presentation of where we are, how we got there, and our vision with respect to health informatics. The topic accentuates drug coding, but our database goes much further than that, and I will explain that too. We can regard ourselves as, one moment, please. Jamaica is in a unique position in that we are the only country that I know of where all health insurance claims for both public sector and private sector are online real time, which means that we are picking up all the electronic medical records for these claims. We mentioned the coding of pharmacy products, because that was perhaps the most challenging in arriving at this position. In that, whereas the United States issues national drug codes, NDC, for drugs that are approved there, only 18% of the drugs in the Caribbean are sourced in the United States. We're getting drugs from all over the world, Eastern Europe, Brazil, Canada, you name it. So therefore, we had to develop a numbering system that took us all the way down to the formulary of the drug so that we can do things like drug interaction, and we can identify the drug so that if an insurance company wanted to give, to pay for vitamins or proteins only when there is another diagnosis or another drug, they could do that. So we developed a Caribbean drug code. And today, all distributors send their new drugs to us to be coded so that it can go to the insurance database at all the pharmacies. And we have staff on board that does that continuously. And because all the pharmacies are online to us, it automatically updates their database by the following morning. National Health Fund and indeed the NIB in Bahamas are supported by the AIS online claim processing system, including the integration of drug codes. And without the coding, it would be almost impossible to control programs such as the National Health Fund, where dependent on the disease, quantities of drugs must be monitored, quantity over time. So unless you can identify each drug, and you might have multiple manufacturers distributing drugs with the same formulary. So to do the count, you must be able to have coding down to the formulary level. So there's integration across pharmacies. Pharmacy chains are able to manage their inventory much better. They can identify where there are locations which are overstocked and move that drug to other areas where they might need to reorder soon. Physicians, we are now applied for approval from the Ministry of Health for electronic prescription because we are introducing remote
telemedicine.
Hmm?
Telemedicine.
Right, we are introducing telemedicine, and without electronic prescription, telemedicine is not practical. In addition to the pharmacies and the drug claims, we have an end-to-end solution for hospitals. And indeed, the University Hospital of the West Indies is the first totally computerized electronic EMR hospital. Our partners are Savannah in India. Our platform is among the top 3 in India. And we have 65 modules going from registration, administration, billing, bed management, inpatient, outpatient clinics, EMR, as we say, and claims adjudication. We covered lab, radiology, etc. The UWI announced in a presentation we did recently that they're saving close to 100 million Jamaican dollars worth of paper having implemented this system. A quick glance, we were founded in 1987. We have 3 tier data centers. One is actually in Canada, one in Jamaica, one in the Bahamas. And because they both fall in the hurricane belt, we have decided to rent facilities in Canada as well, so we can have hot backup outside of the Caribbean. We process about 130,000 claims daily in Jamaica and the Bahamas. As I mentioned, we do the adjudication for the NIB. We have 5,456 up to yesterday providers, doctors, pharmacists, dentists, hospitals, etc., and 1.26 million card holders. We started processing online in approximately 2000. We have had 99.99% uptime, as we must be up 24/7, 365 because of hospital claims, etc. And as I mentioned, we do real-time online claims processing for both public and private sector. Let me just mention here quickly that because all the healthcare providers are online to us for the purpose of insurance claims, they already have the infrastructure to submit other data, non-insurance encounters. And we are using, for the purpose of health claims, or medical claims, ICD 9 and 10 and CPT codes. So we're using standard codes. And this gives us a tremendous opportunity to do extensive analytics. The other is fairly standard. The linked data between insurance and pharmacies and physicians allow us to do coordination of benefit, where people might have multiple insurance, health insurance with multiple companies. And because we process for everybody, coordination of benefit is possible. We support disease surveillance and cost control. The National Health Fund in Jamaica provides subsidy for 28 chronic diseases. And we're pleased to mention that recently they added dementia. And as a consequence of that, they're able to track high burden conditions like hypertension and diabetes. A quick reflection here from the statistics that we have. You might find this interesting. I am sure that in time they will be able to provide data that is more specific to dementia. Go ahead, Sheikh. As I mentioned, we have three-tier data centers, ensuring high level of security. And that we take very, very seriously. We are now working with the university to add other public sector hospitals to the AMR. And this will avail them of a tremendous amount of data for research. This combined with health insurance claims data, where we have literally millions of records, EMR records representing health claims, gives us unlimited possibility. We are positioning Jamaica as a regional digital health leader. Right now, we are integrating AI into our platforms. We want to build resilient and intelligent healthcare systems to enable monitoring not only of digital claims, but all encounters. We're supporting regional digital health excellence. We are now also in the Bahamas, but we hope through our partners, Sagicor and Guardian, to get into Trinidad and Barbados and the other countries, be are now working on Cayman and so on. So we believe that we could be a very good partner for those organizations needing research information. And we can do a deeper dive in the question and answer session. Thank you very much for this opportunity.
And thank you, Doug. Thank you and what you've been building with AIS, which is incredible. And the links between the data with the public and the private health system, that is really, truly incredible. And I think it has a lot of potential, as you mentioned, a lot of transferability and applicability to other countries in the region. We know that this has definitely it's not enough time for us to talk about all of the things that we want to talk about, because we have about 15 minutes and we want to open the floor now to hear from any of you who would like to respond, share from your own experience or your own expertise. So the floor is open. Michelle?
Hi, because I don't want to wait. I wanted to give other people an opportunity to speak, but then as we have so little time, I just want to jump right in and say, you know, I am very heartened by all that is happening, and even having been invited to this platform here. I still get a little concerned though, that with all that is being done, we still seem to view dementia, and particularly Alzheimer's dementia, as just an old person's thing. And when the person is old, then the doctors don't do really too much. I am glad for people like Roger, neuropsychologists, because we too often have simply psychologists who prescribe psychotic drugs to people living with dementia. And I get a little anxious that we still have not been able to move ahead with really concentrated effort on people living with dementia and Alzheimer's simply because they're old. And so we put them aside. I mean, I don't know what we can do here about that, but I still, you know, I'm still working. I'm from the Alzheimer's Association, past president of the Alzheimer's Association in Trinidad and Tobago. And so I continue to do what I do. Okay.
Well, I think, Michelle, your observations are keen, and the dialogue that's coming up on the 25th of April, it will have a lot of focus on advocacy and public awareness and how we really increase public awareness. So I think you're spot on. There is a lot of stigma still, and that really prevents people from actually seeking care. It contributes to families even not even seeking help when they need it. Because we have limited time, I want to quickly hand to Bloss.
Thank you, Ishtar, and thank you, speakers, for a really wonderful discussion. I was just wondering, a question out to the speakers, in terms of the context of current systems and what's available across the region, I'm wondering what potential there might be in terms of AI technologies. So I'm thinking AI technologies to track medications that are coming into the Caribbean, in terms of tracking supply chains and the integrity of them and their expiry date. Also AI in terms of opportunities for training. So virtual reality, particularly in individuals who are out in remote regions. We're exploring that in terms of Australia here, how to get virtual reality headsets to be exposed to people living with dementia. Also enhancing health literacy within the population, you know, in terms of the stigma that was raised by the last question, and understanding and knowledge about risk and how we might utilise systems or electronic systems within the Caribbean and across the countries to get those messages out, and where really the Caribbean is out in the opportunities to do that in terms of technology advancement. But just a thought around that. Thank you.
James, Doug, any of you want to speak to what you all are doing in terms of some of these things?
I don't know. I don't have an AI tool yet to track the some of these things. I'd be interested to find one. I'm on a digital health conference in Berlin this week, actually, so that might add to my list of what I need to find.
Yes, especially if you're tracking that data, if you've got, you know, what's going out.
From our own system, certainly, but in terms of us tracking the parallel trade itself, I don't know exactly what's come from Turkey into our region and what exactly it is. I don't have the data for that. It'd be interesting to know how I could get it, but I don't have the data for that.
Doug, does your system track
Yeah.
that?
Because of the Caribbean drug codes,
Yes, we are out of
we can track, and the Caribbean drug codes are not only available to insurance companies that are using our system, but to anybody. If you want to use that in any other country as a means of measuring your drugs and licensing drug interaction and these other things, we'd be happy to do that. But you're right. For many years, we have been advocating a regional approach to challenges. I don't believe that we do regionalize some of these challenges as much as we could. Yes. Earlier, a speaker mentioned that maybe the government should charge more for registration of drugs and do a better job and a faster job. We have advocated this on numerous occasions here in Jamaica, that we have all the facilities to help them with the registration and the coding and so on. But we have not gotten a bite on that bait yet. But this is something that we should discuss at a regional level as well. We'll be very happy to.
Mm-hmm. Rochelle, I know I see Edna's hand up and Regina, I see your hand up, but Rochelle, did you have
just actually just a very quick thought, and maybe not the most helpful, but my initial reaction was, you need to digitize the data before you think about artificial intelligence. And what I've seen is that actually we need to bring a lot of the activity out of the shadows and into digital spaces. And then you can think about more sophisticated platforms and systems for processing that data. But I would absolutely agree from the market's perspective that unless you get more transparency on import data, on procurement data and transactions, and prescriber data, it's really a very difficult ask to start to be able to do demand forecasting, market aggregation, and other kinds of market shaping activities that are so essential to be able to assure suppliers that there are the volumes around and that there's the type of market that they want to be able to enter with the right kinds of payment systems, etc. So it was really just a plea, actually, just to think about, the kind of digitizing the data and bringing it out of the shadows as a preliminary step.
Yeah.
Well, let me address that. What we are trying to do, and what we are doing, is that we are digitizing every health insurance claim. Every medical claim has a CPT code and an ICD-9 or 10 code. This is what you need to do data analytics. All the pharmacy claims have a code number that tells us the formulary of the drug. There is no more comprehensive, and at the University of West Indies, they're paperless. From registration, clinic, inpatient, outpatient. So we have all the data. What we're trying to do now is to, in partnership with the university, hospital, and the university itself, is to go further into computerizing more hospitals for EMR through them. We also have private hospitals that are on the system. So we have the electronic medical record. Jamaica, as I said earlier, is in the best position in the world to have real-time live health data.
Thanks, Doug. We are pressed for time, so I want to hand over to Edna and then Rajini and then Leslie.
Yes, good morning. My question goes specifically to the area of genetic testing that was mentioned. One of the concerns that I have is familial DNA. Is there anything being done in terms of the collection of data around familial DNA, because we see clusters of Alzheimer's disease within family and within generation of family. So I would be curious as to whether or not there are any diagnoses, or data collection within that area.
Thanks, Edna. I know, Rajini, you might have some thoughts about this, and Sylvia. And I also want to signal that at the next dialogue, we'll also have Dr. Karika Weldon, who is the founder of Carry Genetics, and they're starting to do work in this space as well. Rajini?
Hi, good morning, everyone. Thank you so much for inviting me to this discussion. It's really been wonderful. So first, I'm a human geneticist. I work at UE in St. Augustine, Trinidad. And Sylvia did a great job of kind of surveying what is the state of the field of genetic diagnostic testing in the region. Now, there are kind of two issues. One is we can test for genetic mutations that are already known to cause disease in populations, mostly not our populations. These have been discovered elsewhere. And there is clearly some utility in that, but it's not clear how well that translates to our population and whether those same tests that we are performing are necessarily as reliable in terms of a diagnosis in this population. It all depends on the genetic background of the base population, and we just don't have enough data about this region in that format. So to answer your question about familial studies, there's a fair amount of genetic research going on. It has its own complexities and its own sort of limitations. Just as you spoke about the regulatory limitations with the drugs, we have challenges around getting ethics approval for doing studies across different territories and so on, because of different processes in the different islands. And in order to do high-power genetic studies, you need large numbers of participants in these studies. So one approach is to do a large, like, case control kind of study. We can also do familial studies, Edna. So that is looking in large families where disease is progressing and looking to see if we can figure out what's the genetic cause there. And those have actually been quite tractable in our region, and myself and others are involved in this type of work. So that certainly is a mechanism to discovering known or novel genetic causes of disease within the Caribbean context. I also wanted to, I hope that answers the question enough.
Yes.
I also wanted to just draw your attention to another possibility that is another opportunity that can come from genetic testing. So Sylvia gave a great description about genetic testing for diagnosis, but in just sort of hearing all of the discussion around efficiencies of getting medicines into the region and so on, there is the opportunity of pharmacogenetics, which is looking for genetic mutations that actually affect how patients would respond to certain medications. And I just want to highlight a study we recently did on clopidogrel or Plavix, which is kind of one of the most used cardiovascular disease medications. There are certain mutations that cause a person to be resistant to that medication. And so if you know that you have that mutation, you would not be prescribed that medication. We've actually found very high rates of this resistance mutation in Trinidad, indicating that maybe we need to be looking at alternative medicines for our population. So this can also kind of help with the efficiency of deciding which medications we should import and at what volumes and so on. So I just wanted to put that out there as another possibility of how we can use the genetic data in this region.
Really significant. Regina, I'm sorry to cut you, but I would love to hear
Sure.
from Leslie and Carol
Yeah.
before we jump off. But you raised some really significant considerations that I think need to twin with the data exploration too.
Yeah.
I'm looking forward to picking up. Leslie and then Carol.
Hi, good morning, everyone. Thank you so much for the invitation, Ishtar and everyone. I am an occupational therapist. I'm based in Trinidad and Tobago. I was at University of Nottingham with Blossom. I'm kind of a summarizer person because I know we're at the end of time. I'm not going to presume I can summarize. It's not my place. But from my perspective, as a person who is been looking at dementia in the Caribbean, in Trinidad and Tobago, particularly for the past 15 years as an OT, I just find it interesting that Sylvia pointed out that in genetics, there's a need for personnel development. It's something that's specific to the region. The brain drain is something we've been dealing with for decades now. And I was very interested in the first presentation from Dr. Roberts that really pointed out the two main areas of need have to do with the carers, the informal carers and the formal carers. And so it's great that this presentation has covered a lot of the pharmacological approaches, but the non-pharmacological, the psychosocial side of things, I think, which is the personnel development. My piece that I want to say is this is something that should not be overlooked in the report that you're going to be making later on in May. This needs to be addressed. It will address, as Michelle said earlier, about stigma. That kind of work, I would love to see it tie in with the pharmacological industry as well, because that's how funding might be a potential collaborative approach. But the psychosocial approach is desperately lagging behind, and I'm putting a plug for that. The therapists who train the people to do the caring work on the ground in a skilled manner is what the research is showing really makes a difference.
Thanks, Leslie. I'm going to have to stop because we are at time, and I do want to hear from Carol before we leave. But again, this is one dialogue. We cannot go into everything, but come to the one on the 25th, and next year in Jamaica, November, save the date, we are having a Caribbean Brain Health Summit. Amaji is hosting that, and you'll hear more about that. Carol, please, we'd love to hear from you.
Thanks very much, and thank you for inviting me. This is a really important discussion, and really the thing that I wanted to highlight is the need for a sort of step back and a reflection on all of the data. So we've heard about the really important potential for clinical data or data for people who are in contact with health systems of various types and with pharmaceutical kind of those kinds of trajectories and supply lines. It does need to be grounded in the epidemiology, the understanding of the epidemiology of dementia within the Caribbean and across the islands as well, and in different parts of the Caribbean, because it may vary across different settings. And that kind of highlights the vital importance of descriptive epidemiology. And there has been excellent descriptive epidemiology in the Caribbean, but it's worth stepping back and saying, do we need a working approach, a working group, maybe in the discussions going forward, to think about what are the data that we have and what are the data that we need in order to judge what we do upstream for dementia risk reduction, prevention into the future, for what the role of early detection is, or timely, where timely diagnosis fits in the cultural settings within the Caribbean, and also what, as has just been said so eloquently, how to support those people living with dementia in an effective and as far as possible, evidence-based manner. And that all needs ground epidemiology, which is sustained across time in order to create the models that Derek was talking about, because we fed the models from our population studies into the work for the UK that are similar to those that Derek described, which come from the same LSE stable.
Thanks, Carol. Yeah, and I'm glad, and I see Trevor has been in the chat talking about and trying to engage with Doug around the data. So has Nahia, and Doug and I have also been in conversations about data and data access. The epidemiology part of it is not lost on us, and the need for that grounding and the need for the solutions that we're developing to be truly evidence-based in terms of how the disease has been evolving, the prevalence of it, the incidence of it. And so we will be working really closely with you and with Plata and the larger group on this. Roger, we are over time, but Roger, I as co-chair, and then to hand over to Lenny as well.
All right, thank you. Just a few quick points. I think that we spoke about the genetic testing, and I would also want to mention about biomarkers. Individually, we may not be able to build out services for our own countries, but collectively, we should be thinking about regional service for both genetic testing and biomarkers to aid the diagnosis. The other point that someone raised about the overprescription of antipsychotics, I think it's linked to the fact that we have deficiency in the non-medication interventions for people living with dementia. Once you get occupational therapy on board, you have your carers training in doing behavioral charts to understand that the agitation might be communicating the need. And once you get those optimized, you find that the need for antipsychotic become less. And in bridging the gap between the urban and the rural centers, I think that let's use the lessons from COVID-19. I think that telemedicine is going to play a significant role in that.
Thank you.
That's it.
Roger. So before I hand to Lenny, I just want to say thanks to all of you for being part of today's dialogue. I think we've just experienced exactly what we hoped for, which are deeply insightful contributions, very honest reflections, and a shared recognition that while these challenges that we're talking about are very real, so too is our collective capacity to really confront them head on. So dealing with these gaps in health data systems, regulatory fragilities, access barriers, but we also have in the place things that are working. So EMRs, drug coding, data, strong researchers in the region who are willing to work together and collaborate across public and private sector that is willing to build out the types of infrastructure and to work cross-regionally and globally to ensure that we have that. And so many of you, we look forward to having you be part of this continued conversation that is very anchored in the Caribbean, our shared realities, our realities as small island developing states, the strengths that we bring, as well as, let us be frank, the historical inequities that we must navigate. So I want to end by saying, before I hand over to Lenny, that I want it to be said that the Caribbean has something very powerful to offer to the global brain health agenda. And we need to be really purposeful about what we do and how we choose to adopt, adapt, or resist from the global narratives. So I hand over to you, Lenny, to wrap us up and to again invite you to stay tuned and join us again on the 25th. Over to you, Lenny.
Yeah, so aware of the clock, I'm just going to say thank you very much to you all for participating from wherever you are. I don't know if you can see, but the sun is streaming into off the hills of Wales right here, right now, and I'm definitely feeling the heat after an hour and a half of very interesting conversation. Thank you all for participating. We will be sending out a link to the subsequent meeting that was just referred to, and we'll circle back with the people who spoke when we produce the transcript of this meeting. But with that, I shall let you enjoy the rest of your mornings, afternoons, and into the evening here in the UK. Thank you very much for coming on and taking part. Thank you.
Thank you to all of you. Thank you to all of you. So have a good rest of your day and look forward to continuing the conversations. Follow up with us as you'd like. Welcome that. Take good care.
Thank you.
Thank you.
Thank you.
Best.